Happy Friday, everyone. Welcome to Conversations on Care, a Facebook talk show bringing together our healthcare partners, our clients, and caregivers to help families better understand and cope with their aging parents with chronic care needs. My name is Julie Collada, and I'm the founder and CEO of Open Arms Solutions. And Open Arms is a home care company serving the Chicagoland area, focused on inspired home care solutions for seniors with chronic conditions such as dementia, Parkinson's, and other movement disorders. It is truly our mission to help our families through this journey and to know that their loved one is living their very best life possible. If you like these dialogues and you find them helpful, please give us a like and a share so this information can get out to more people who could benefit from it. With me today is Dr. Jennifer Wilson-Binotti, who is the owner and clinical neuropsychologist at Compassionate Neuropsychology. And Jennifer, this is your second time with us on the show, and thank you so much for coming back and sharing your knowledge with everybody.
Thanks for having me, Julie.
My pleasure. So our topic today is not all dementias are the same. How to identify and best support your loved one with dementia. And I'd like to read Dr. Binotti's background. She's got a wonderful background for this important work. She is a licensed clinical psychologist and a neuropsychologist specializing in the assessment of older adults. After completing her internship in community mental health in New York's Hudson Valley, she began working with the senior population in her postdoctoral work. She is experienced with those aged 50 plus with increased anxiety or depression or a decline in functional or cognitive abilities. She is the owner and sole practitioner of Compassionate Neuropsychology, LLC, and evaluates patients at nursing, rehab, and retirement facilities and private residences. She's also on staff at Linden Oaks Behavioral Hospital in Naperville. Welcome again.
Thank you.
What inspired you to start Compassionate Neuropsychology?
Well, I'd like to say that there was something in my family, a family member or something that inspired me, but it wasn't that at all. I actually tripped into it. My philosophy when I was doing my clinical training and postdoc work was to take in as much different experience as I could. And that way I could better assess what I would like to do or what my strengths are. And so in my postdoc work, I wasn't particularly interested in working with older folks, but it presented itself. And so I did. And I found that I had a really good rapport with older people and that I had a particular skill for assessing and doing testing instead of therapy. Most people go into psychology thinking they want to do therapy, and I did as well. But it turned out that that wasn't what I wanted to do, that I wanted to do assessments, and I ended up wanting to work with older folks and assess the neurocognitive disorders. And after I got training at a neuropsychology practice, I went out on my own.
Good for you. It's always that you and I were talking about this a little bit before we went live. It's a bit of a leap to start your own company, so it takes a lot of courage to do it. And you've obviously been doing it for how long have you had your practice?
It was 6 years ago I started it.
Good for you.
Yep. It's been very rewarding.
Yeah.
Really, really wonderful.
Yeah, and it's so needed.
It really is.
So our topic is, talking about dementia and the different kinds of dementia. And I find that when I talk to people, thank you for putting that up there, Alex. It's actually not all dementias are the same. How to identify and best support your loved one with dementia. Dementia is really an umbrella term. right?
It really is an umbrella term. I get the question a lot. What's the difference between Alzheimer's and dementia? And they're not. Alzheimer's is a type of dementia. And like you said, Julie, the umbrella term is dementia. So dementia is separate from the specific definition that applies to neuropsychology. Dementia means that you have a neurocognitive disorder that indicates there is a change from your previous level of functioning, and it impacts your ability to do your everyday tasks, your activities of daily living, and your instrumental activities of daily living. They're impacted, and so you have to take steps to compensate for that loss.
Okay, well, thank you for that definition. I hadn't heard it quite that way, but it makes a lot of sense. It's a very practical definition.
Yeah.
So then the natural question after that is what causes dementia?
Oh boy, that's a very good question. There are so many causes. So if you think about what we just talked about, what dementia is, there are all kinds of things that can cause a change in neurocognitive functioning, right? So the most common one, at 70% of all dementias, is Alzheimer's. Okay, so there are different causes for that. That Alzheimer's has a strong genetic basis. So we do see that running in families. However, people can develop it that don't necessarily have a strong genetic base. So we call those lifestyle factors that contribute to Alzheimer's dementia. Usually it's a combination of a genetic basis for it and then lifestyle. So if we're talking about lifestyle, we're talking about things like heavy alcohol use, smoking, obstructive sleep apnea, high red meat intake, poor exercise, those kinds of things you hear from your doctors all the time, right? And obesity, diabetes. Okay, we hear these from and they're serious when they say that. They do contribute. Also, mood disorders can be risk factors, such as depression and anxiety.
Yeah.
Okay,
Yeah.
we have a lot of things that contribute to Alzheimer's. And then, other than that, we have things like a traumatic head injury in an accident. We see that in young men, 18 to 24. They haven't developed the frontal lobe. There's a lot of testosterone. They get in bar fights, they get in accidents, they incur a head injury, and boom, they have dementia. Okay, yes, that word is applied to young men when they have a brain injury. Also, if you have if your brain is deprived of oxygen for an extended period of time. I had a patient who fainted in the hot tub and she was deprived of oxygen for 10 minutes and she ended up with dementia. And it was in an unusual pattern that only affected her memory. Toxins can cause dementia. Substance abuse, we see that when there's been a lifelong history of heavy alcohol use or drug abuse. They can have permanent dementia from that. Pesticides can cause that in Parkinson's sufferers. We're finding that out. So there are a lot of causes of dementia.
Thank you for explaining all of those. So can you describe some of the more common types of dementia? You mentioned Alzheimer's, and 70% of all dementias are Alzheimer's. Can you just take a little time here and what are the most common? I mean, I recently read that there are over 50 kinds of dementia, right?
At least.
At least, yeah. So we don't have time to talk about all 50.
No, but we want to talk about the most common ones. Yeah.
Well, let's talk about the most common.
All right, let's talk about that. So Alzheimer's, as I said, comprises about 70%. Right. Now, we got a little wrinkle in the cloth here. So in 2019, researchers discovered a new type of dementia that we had previously been diagnosing as Alzheimer's. And it's an Alzheimer's lookalike, and the acronym is LATE, L-A-T-E. And it stands for limbic predominant age-related TDP-43 encephalopathy. Basically what it is it is a dementia that develops in folks in their late 80s and into their 90s, and it is an Alzheimer's look-alike, but it is not the same accumulation of the plaques and tangles. It's an accumulation of a protein that precludes effective functioning, but it is different in that it doesn't always have the same behavioral aspects of it. And it doesn't have the same problems in terms of caring for the patients.
Can you describe that one more time?
I sure will.
Well, tell me the name one more time, because truly this is, I don't know that I've read about this or heard about this. So
Yeah,
this
no, it's just not. In fact, I just saw a figure the other day, and I think it is accurate. My experience.
You know what, Dr. Binotti?
Yes.
When you pull away,
Yeah.
The sound cuts out. So if you could try to, thank you. Because what you're saying is so important. We don't want to miss a word.
Sure. So I saw something the other day that they're saying that they think about 40% of dementias are this late type of dementia. So that stands for limbic predominant, age-related, TDP43, that's the protein, encephalopathy. It occurs in folks in their late 80s and through their 90s. And these are people, and I've seen these over the years, and that I've been doing this, and it is like Alzheimer's, but it doesn't have the same kind of disorientation in time and space. It doesn't have the same behaviors that go with it, the same kind of paranoia. It doesn't have the same really troublesome kind of things that the wandering. And that's still up in the air, though. This is I'm speaking from my experience. So I had a series of people that I saw yesterday at a facility, and there were a couple of them that were in their 80s, and they clearly had, to me, Alzheimer's, based on my experience, what I know about Alzheimer's, and that they were disoriented in time, and then very, very poor delayed memory. And poor object naming. These are the cardinal signs of Alzheimer's. And then I saw this woman. She's 96. Okay. She looked wonderful. And she says, I know I've got really bad memory. Now, usually people with Alzheimer's, they don't know it. They don't believe it. Okay. It's like, oh, there's nothing wrong with my memory. Well, and so she says, I know I have really bad memory, but what are you going to do? I thought that's true. So we did some testing. That memory was no longer than 2 minutes, but she didn't do a lot of repetition, and she was still generally oriented in time. There was no paranoia, and I thought this is a classic example of that late dementia. Okay, she wasn't going to wander, and the upshot was for her care planning, we didn't feel the need to move her to memory care because she wasn't leaving the apartment. She wasn't paranoid. She wasn't wandering. She was oriented to herself fully. And her daughter was very involved. And so we decided, with the facility, decided that she can stay exactly where she is.
So that's a perfect example of why really assessing what kind of dementia it is. That's a great example.
Exactly.
So what other kinds of dementia are very prevalent?
Okay, so the second or third most common is vascular dementia. We see this in people with chronic strokes. Okay, so it's in testing, there is a different profile. That stated, there's only about 10% of all dementias that are pure vascular.
Oh, that's interesting statistics that I had not heard. My mother was diagnosed with a mixed dementia, vascular disease, and Alzheimer's. But I never heard that statistic that only 10%.
That's right.
That's interesting.
Most people that develop vascular dementia, it will cascade into an Alzheimer's mixed process. I see that all the time. I would call that combination more prevalent than probably the second most after Alzheimer's. Very, very common. If I see a medical profile that says history of TIAs,
Yeah.
COPD, diabetes,
Mhm.
hypothyroidism, which, by the way, is a new factor they're discovering is contributing. Okay. Um, Atrial fibrillation, pacemaker. I'm like, okay, I know where this is going. And then I go through the test and then,
Yeah.
yeah, looking for the stages and behaviors, that kind of thing.
So okay, so we talked about the top three different kinds. And so then what are some of the other more prevalent on the list?
Parkinson's. Yeah. So there's Parkinson's, just Parkinson's
Right,
disease.
right.
And they're largely intact cognitively. That being stated, I think that everybody with Parkinson's is, as it gets to the later stages, they have dementia. Okay. It's just less so. And then there's Parkinson's with dementia. And that is a different cognitive profile in testing than the others. Okay. So most of the time when I assess someone with Parkinson's dementia, I already know they have Parkinson's. They already have the diagnosis. There have been a handful of times that I've actually done the testing, observed the patient, and put in the report that the doctor should make an assessment for Parkinson's, because I'm of the opinion that there probably is some.
Hmm. Yeah.
Yeah.
And, then there's, often there's something called frontal temporal dementia, right?
There is. Now what we look for there is that occurs in people in their 50s and 60s. Okay. And it has a genetic basis.
Hmm.
That doesn't mean it's always genetic. We don't know exactly. But so, I mean, sometimes, people say, well, it's nowhere in our family. But they're finding that there is some relationship with ALS and frontal temporal dementia.
Oh, wow.
So if I ask the question, is there any frontal temporal dementia in your family? Well, no, not at all. Anyone with the ALS? So that's the next question to ask.
Uh,
So it is a devastating disease that time from first signs to end of life is generally 7 to 10 years. And what it appears as is different based on where it starts in the frontal lobe.
mm,
All right. So there are some versions of it that start in the language center. Then there's others that is the most common, starts in the behavior part of our brain. In most people, that's in the right hemisphere, the right frontal lobe. And people that never before, who were, say, for example, sexually disinhibited, um, or are now eating everything in sight, or they're shopping like a mad person, spending money. When you start seeing behaviors like that in someone that's about 50, 60 years old, 65, you've got to start asking that question. And the first thing you want to do is get an MRI.
because that's the thing that I think I've learned anyway throughout the years. When my mom was first diagnosed, it was such a mystery. Had no idea why it was happening, and really didn't understand, well, so much about dementia. And I think that's where most people are.
I
And
agree.
I think that um, once people, and we went through this with my mother-in-law too, and I was trying to help my husband and the family better understand what was going on with their mom. Is that once people start to understand that there's different parts of the brain, and the brain is
Mhm.
really starting to break down,
Yeah.
and depending on where it breaks down, will determine, you know, what the behavior is that we tend to
That's right.
call it. And so, when my husband walked in and his mom said, "Who are you?"
Oh,
Which is always incredibly
oh,
devastating,
oh
right?
God, yes.
And,
Yes.
I tried to help him understand that, well, hey, this is, the hippocampus is part of the brain and this is the part of the brain that's just not working, Mark. And it's
Right.
hard. It's hard to hear it, but I think, at least from my personal experience, and when I talk to people, and I don't know if you found this too, it's easier for family members to deal with it if they understand more concretely that, it's kind of like breaking your leg. It's something's broken,
Yes,
you
it
know,
is.
and it's just more, it's more concrete, I think.
Here's a little tip, and I think this is really important. Because people with Alzheimer's revert back in time in their own memory, Mark should have presented a picture of himself as a child and said, "Who is this, Mom?" "Oh, that's my son, Mark." And then he says, "That's me, Mom."
Yeah, that's
So
a great
really
suggestion.
helpful.
Yeah, that's a very helpful suggestion. We have some viewer questions, so I want to make sure we get to those.
Okay.
And this is a great one. The first one is there a test for this new late form of dementia? Is there a test?
Yeah, I don't know the answer to that. I'm going to speculate that we do have tests now where we can look for a certain protein in spinal fluid to diagnose Alzheimer's. Okay. I'm going to go out on a limb and say we probably can do the same thing for this late thing. That would be a laboratory test. As far as neuropsychological testing, it would be the same. I would go through the same process to diagnose that as I would any other dementia. And it would be based on just an opinion based on the testing results. And it certainly, the person would have to be at least in their mid 80s and older for that to apply.
Okay, thank you. Thank you for whoever asked that question. Another viewer question. This is a good one. How can we best prepare our loved ones with dementia to plan for a time when they may be less able to where that senior is less able to engage in decision making?
Oh, that's an excellent question. That's a whole other seminar. But what it is when they're able to, anybody 18 and older should have all those documents in place, because at any time, any one of us can become incapacitated and need someone that we trust to make decisions for us.
And you're talking about power of attorneys. So power of attorney.
Powers of attorney. That's right. And that's what you do. And so you're going to need to corral your folks or your spouse or whomever to get these documents in place. It is so important that those wishes be known ahead of time, because when they get to a point where none of this is making sense to them, you have an ethical obligation to follow through on those things that they said they wanted. Even when they get mean and angry and all that kind of stuff, which is a result of the dementia, you need to follow through on those things for them.
Yeah, and I will tell you from personal experience, because unfortunately, I didn't know you at that time, so no one advised us on that, and then, it was too late. We weren't able to really get a good answer from.
Right, so
my mom wasn't able to tell us what she wanted and what was important to her, and that's why I'm so passionate about that topic that you just described. Nobody wants to have that uncomfortable conversation.
No, they don't, but it's really important. And I could say, and this is a whole nother seminar as well about an individual's capacity. There are two different kinds of capacities. One is the capacity to make decisions. Most people with dementia don't have that any longer. But many people with dementia have a testamentary capacity, meaning they're able to still say, "Oh, I want you, Julie, to be my POA." Okay. Now, testing would help to determine that. And the person cannot be under undue influence from, say, another child or, something like that. And so that's part of the evaluation.
Do you get involved in those scenarios?
Sometimes.
Are you brought in as an expert, I would imagine?
Sometimes, yes.
Yeah.
I do.
Yeah. And, I think, I know for our care coordination team, there are scenarios where, we learn that, we just really have to get all the information from a family. to really
Yeah.
understand what's going on in the dynamics of that family,
That's right.
to help the process along, to make a good decision. Because sometimes, we'll have, and I'm sure you've seen this before, we'll have clients that are very insistent that they have the ability to make decision, and just all the, without us being experts, all the evidence that we see, that's not necessarily the case. And then you can have siblings that aren't on the same page,
That's right.
and then that just complicates an incredibly important decision for their loved one. So
Absolutely. And then who suffers is that loved one. And you
right,
want to say, people, stop. We
right,
need to focus on the parent here,
right.
or whoever the individual is. Yeah. And you don't want to be caught in the middle of that.
No,
You'll never win.
no, it's not. No one wins in those scenarios.
No,
That's why it's so
exactly.
important to have those discussions
That's
when
right.
people have the capacity to really, share what's important to them, and then you can document that.
Yeah.
And then it doesn't make it any easier when you need to, if you have a senior that's very frustrated and they forget that they said that, and they forget that they wanted you to be,
That's right.
power of attorney for healthcare. But, from personal experience, I will tell you, it is more difficult if you don't know what they want and you're guessing.
Yes, it is.
If you know what your loved one wants, then
Right.
my view is you can put up with everything else, because in your heart that's what they told you, and that's what
right.
That's what
That's
they
right.
want. We are getting close to being end of time, and there's other things that we want to cover, and we're not going to be able to cover everything, of course. And I really love the fact that you referred to that. That's another segment. Because there's so much to talk about.
There's so much.
So let's talk about the if you suspect your loved one has dementia.
Oh,
What do you advise? What's the next step?
I know if all you have is a hammer, everything looks like a nail, but I'm going to go ahead and say it. You get a neuropsych evaluation. That's because you need to know what you're looking at, how far along it is, what the particular profile is, what to expect. You just need that information. Otherwise, you're just stumbling in the dark.
So you can certainly call someone like yourself,
right,
at Compassionate Neuropsychology. So for anyone who's listening in, Dr. Binotti's information is, I believe, being displayed right now.
Yeah, I do want to mention just very briefly, just so people understand, Medicare Part B covers 80%, and a supplemental policy covers the rest.
Great.
Okay.
That's great news.
Yeah.
Thank you for saying that. That's always important to share that information. Do people in general, should people in general start with their primary care? Or in many cases, should people go directly to a neuropsychologist?
No, I think consultation with the primary care physician is an appropriate thing to do. He or she may refer to a neurologist. They may, simultaneously refer for a neuropsych eval. Many doctors have their own preferred neuropsychologist they send to. I think it's best to start with the doctor and keep the doctor in on it throughout.
Yeah. And then, you talked about all sorts of potential causes
right,
for dementia. And then I would imagine you collaborate quite a bit with the primary care physician.
Collaborate. And the rule of thumb is you want to eliminate any medical issues. Okay, before you start going after a dementia, get a UTI can cause delirium, and all kinds of other things. So you look at the medical things first, and that's why I take such a thorough inventory of the medical history.
Yeah, that's so important. It's always we've been talking about some non-reversible dementias today, right? Alzheimer's and Parkinson's and vascular dementia, but there are reversible dementias. And those are always so exciting when you identify something that potentially, if medically addressed, you could bring back strong cognition. And,
that's right. And one of the things that occurs, and I know we're running out here, but one of the things that occurs in older folks is depression, and that can appear as pseudo dementia. And once the dementia or the depression is treated, they come back.
Yes. Yeah. And you mentioned UTIs.
UTI, it's a big thing.
I never thought I would be, so happy to hear someone has a UTI.
Right, that's right.
But in this field, that can be great news, right? Because that
Absolutely.
can be antibiotics.
Because it's just a UTI.
Because it's just a UTI. Right.
Right.
Exactly right. Well, a pleasure again. Thank you so much for your time and your expertise. I'm sure this was very helpful to all who tuned in.
Great. Thank you for having me.
Oh, our pleasure. Thank you. Bye-bye now.
Bye.